Welcome to our first ever live webinar. It's a collaborative webinar. We are actually collaborating with TriSalus Life Sciences and the Ocular Melanoma Foundation. I'm your host, Danae Peterson from the I Believe podcast. And we just want to, again, send a special thank you to Ocular Melanoma Foundation as well as TriSalus for coming and bringing this together. We had over 117 participants register for this webinar, and it is amazing to know that that many of you guys are committed to learning and just committed to being here. So first, we're going to actually be hearing from 3 experts from the PERIO-01 Clinical Trial. So the Pressure-Enabled Regional Immuno-Oncology, or PERIO-01 Clinical Trial, is actually studying a new investigational drug, SD-101, delivered intravascularly by TriNav Infusion System using the Pressure-Enabled Drug Delivery, or PEDD, method of administration. The study is currently evaluating if this platform approach can improve the performance of systemic checkpoint inhibitors in treating patients with uveal melanoma liver metastases by overcoming 2 major challenges in treatment: immunoresponse suppression and ineffective drug delivery. So first up, we're actually going to be hearing from Dr. Richard D. Carvajal, MD, Associate Professor of Medicine, Director, Experimental Therapeutics, Director of the Melanoma Service at Columbia University Irving Medical Center. And he is an investigator on the PERIO-01 clinical trial. Dr. Carvajal will discuss the success, challenges, and emerging strategies in the treatment of metastatic uveal melanoma. Following his presentation, Dr. Stephen C. Katz, MD, FACS, Chief Medical Officer of TriSalus Life Sciences, will discuss barriers to immunotherapy, success in uveal melanoma liver metastases. And to conclude, we're going to hear from Dr. Joshua L. Weintraub. He is an MD, the Executive Vice Chairman, Department of Radiology, and the Chief of the Division of Vascular and Interventional Radiology at Columbia University Irving Medical Center. And he's going to be speaking to us about the Pressure-Enabled Regional Immuno-Oncology, or the PERIO-01 clinical trial for adults with uveal melanoma liver metastases. After their presentation, we will have a Q&A session in the chat. You can actually submit via the webinar by clicking the Q&A button down at the bottom of your screen in the Zoom webinar. And you can also send us questions via Facebook. And again, we will get those questions to post to you at the end. Joining us to discuss the TriSalus Life Sciences PERIO-01 clinical trial eligibility criteria is Ashley Moody, and she is a nurse and a clinical research and immunotherapy project manager. So she'll be available at the end to answer those logistical questions surrounding the trial involvement, like eligibility, trial flow, treatment logistics, and travel reimbursement, if applicable. And then you can follow the presentation towards the end so that we can get those live questions. So Dr. Carvajal, I'm going to go ahead and turn it over to you.
Danae, thank you so much. And I'd like to thank Ocular Insights, the Ocular Melanoma Foundation, I Believe, everyone in helping put this together. So
yeah, thank you for being here.
Oh, no, my pleasure. And I have to say, I really enjoy, I think these sorts of forums are so important because I think as a clinician, it's so important to be able to help educate and guide patients, not just patients of ours at Columbia, but everywhere. So I do think that this is really, really important. One thing that let me do full screen. One thing that I like to highlight when I talk is one, how important collaboration is in all fields, but particularly when we're dealing with rare and difficult to treat cancers like this. And thankfully, the uveal melanoma field is extremely collaborative. And there's strong working relationships between the clinicians and patient advocacy groups, such as this one here. There's strong collaborative relationships between physicians, and there's strong collaborative relationships between us and pharma. And this is all really, really important to help make sure that we're advancing the field, finding new treatments, and hopefully reaching a cure for patients with disease as quickly as possible, right? We can't do that fast enough. So in 10 to 15 minutes, what I want to talk about is a little bit about the successes we've had in how we are able to treat patients with uveal melanoma, some of the challenges and emerging strategies. Listed here are my disclosures. And I want to start off by just kind of highlighting where we are in the field of cutaneous melanoma. And so if you look at the left hand, if you look here at the left hand, what I just highlight is the number of FDA-approved therapies we have for cutaneous melanoma. And it was really in 2011 when we had the first approval for ipilimumab, the anti-CTLA-4 antibody, and targeted therapies like vemurafenib, that we really started to be able to push our ability to meaningfully improve outcomes for our patients. And in cutaneous melanoma, we're now able to cure 50% of patients with advanced disease, right? We still have a long ways to go, but that's a far cry from where we were in 2004, 2005. And so now we have 15 approved therapies for patients with advanced cutaneous melanoma. For uveal melanoma, thankfully, just in January, we have our first approved therapy. I think everyone in this audience knows about tebentafusp. And my hope is that rapid improvement in outcomes that we saw for cutaneous melanoma, which really began with that first approval for ipilimumab, my hope is that this tebentafusp approval will be kind of the start of an acceleration for this field as well, for patients who are dealing with this disease. Don't want to spend too much time on tebentafusp, but really this is a huge deal. It's practice changing for us, for patients, family members, clinicians. We finally have something that we can do that we know meaningfully improves patients' outcomes. And tebentafusp is the first treatment we have been able to identify that meaningfully improves survival. This is practice changing. Again, this was approved in the US in January. And actually just earlier this week, it was approved in Europe, okay? Now, although we have an approved therapy, there is still a lot of work we have to do. In the way of background, I think everyone here knows what is uveal melanoma. It's a rare type of uveal melanoma. It's biologically, clinically distinct from cutaneous disease. And although the treatments of primary disease are quite good, after radiation therapy, after nucleation, about half of patients will still develop metastatic recurrence. And what's a little bit unique about this disease is when it comes back, it likes to go to the liver, okay? Which is a particular challenge, because if you look across all cancers, whether it be colon cancer, pancreatic cancers, skin melanoma, when it goes to the liver, for some reason, it tends to be harder to treat, right? And so I think as we think about developing new therapies, specifically for uveal melanoma, we have to better understand what's going on in the liver that's making cancer there so difficult to treat. So we do have tebentafusp approved, but we don't have therapies with proven efficacy in patients who are not eligible for tebentafusp, right? Who are not HLA-A*02:01 positive, which is about 50 to 60% of patients, and for patients whose cancer grows despite treatment with tebentafusp. Now, for those patients outside of clinical trials, a lot of us will still try the immunotherapies that we typically use for cutaneous melanoma, the anti-PD-1 antibodies like Opdivo or Keytruda. And they can work. For instance, here's one patient with metastatic disease, and this is about a year or so after treatment of the primary melanoma. She developed low volume disease, so a small lesion there in the liver, a small lesion there in the lung, small lesion there in the bone, a little bit of soft tissue disease there. And this patient was treated with pembrolizumab, the anti-PD-1 antibody. You can see after about a year or so of therapy, the liver lesion basically went away, the lung lesion basically went away, the bone lesion stabilized. And so we can occasionally get responses with these sorts of therapies. But overall, in the general population, unfortunately, it's just uncommon. And this just shows you a bunch of the studies and series that we've done looking at patients with uveal melanoma treated with anti-CTLA-4 antibodies like ipilimumab or tremelimumab, or patients treated with the anti-PD-1 or anti-PD-L1 antibodies. And what you can see is the likelihood of major tumor shrinkage, which we call response rate here, is generally low across these studies and series. So we say the likelihood of major shrinkage is at best on the order of 5 to 10%. This here shows you how long the cancer is controlled on these therapies. You can see it's just way too short. We're talking 4 months at best. Now, in cutaneous melanoma, we will frequently combine the anti-CTLA-4 antibody ipilimumab with an anti-PD-1 antibody. And when we do this sort of combination therapy in skin melanoma, that's what's giving us that very high likelihood of shrinking the tumor of 50 to 60%. And that's a therapy with which we're able to achieve that cure in about 50% of patients. Again, now this can work in folks with advanced uveal melanoma. And this is another patient of mine, a 52-year-old female who, this is the PET scan. You can see all those white spots are spots of cancer. We treated her with ipilimumab and nivolumab. And you can see after 4 months of therapy, most of those spots have disappeared. And after 10 months, the PET scan is basically normal. And so that combination therapy can work. But, again, the outcomes are not as good with this sort of immunotherapy as what we see with cutaneous melanoma. Okay, and so these are the studies and series in patients with uveal melanoma treated with that aggressive combination immunotherapy. And here, at best, we're talking about a response rate on the order of 15, maybe up to 18%. But that duration of disease control, that progression-free survival is still way too short. Okay, and so kind of, bottom line here in terms of for patients who are not eligible for tebentafusp, who are not going to treat on a clinical trial, we do tend to recommend combined checkpoint inhibition. Numerically, the outcomes seem to be better. But to me, the outcomes are still insufficient. So it's kind of a signal, but we have to somehow get this to work better. When we talk about, why does checkpoint blockade not work as well? There are a bunch of hypotheses and reasons why this might be the case. If you look at the cancers that respond very well to these immunotherapies, they tend to have a lot of mutations, a lot of abnormalities that the immune system can recognize and attack. And so this is a plot here, which shows you that, for instance, in skin melanoma, there are a lot of mutations, which is shown over here, and the response rate's really high. If you look at uveal melanoma, it has very, very few mutations. So, that tumor does not have a huge number of changes that the immune system can take advantage of to recognize and attack. So that's one thing. And the other thing is we know that tumors that express a lot of what we call this PD-L1 protein tend to respond better to these immunotherapies. And if you look at uveal melanoma, about 5% of cases will have high levels of expression of that PD-L1 protein versus if you look at skin melanoma, it's about 26%. Now, another thing that I'd like to highlight is that it may be that we need to start looking at cancer at each organ site to see if there are differences. And I just highlight here, even in cutaneous melanoma, if you look at cutaneous melanoma that goes to the liver, the expression of PD-L1 seems to be a little bit lower. And I just bring that up because I think we have to start thinking about differences in each organ, right? We may have to attack cancer in different organs a little bit differently. This is a little bit of a study. This is a study that was looking at some of the immune cells, mostly in uveal melanoma in the liver. And what this shows you here is these CD3 and CD4 and CD8 cells these are your T cells, the immune cells that are supposed to be attacking the cancer. And what this just shows you is that in uveal melanoma in the liver, there aren't that many of them, and they tend to be kind of on the rim of the tumor. They're not able to infiltrate the tumor. Whereas if you look at the tumors and if you look at a different type of immune cell, which are these tumor-associated macrophages, there are actually more of those than those T cells. And they tend to be what we call these bad macrophages, or these immunosuppressive macrophages that don't allow the immune system to kill the cancer, right? And why do I bring this up? It's just, again, we need to understand what's going on in the cancer, in the liver, figure out how to optimize that immune kind of milieu so that our available therapies can work better. Now, all the treatments that we're giving with the intent to kill cancer. That's the goal. But the treatments that we give can also change the way the immune system functions. It can change what we call the tumor microenvironment. And this is from a patient who was treated with tebentafusp, where we did a tumor biopsy of the liver at baseline and then after treatment. And what you can see here is that after treatment, and this is actually at the time of the cancer growth, there are more of those CD8 immune cells there, which should be a good thing. There's more PD-L1 expression, right, which suggests that you might be able to treat the patient with a PD-1 antibody and they might respond better. There's more of this GP100 antigen, no real changes in something called MHC class 1. And why do I bring that up? I bring that up because the therapies we give can also change the tumor microenvironment, which may affect how subsequent therapies work. Okay, and so if we go back to this patient who responded really well to ipilimumab and nivolumab, and we look back at what her prior therapies were, this patient was treated with ipilimumab, the anti-CTLA-4 antibody, and then it stopped working. Then she was treated with pembrolizumab and radioembolization for a while, did okay for a while, but then it stopped working. Then went on to tebentafusp and had that for 20 months. And then after that, we opted to retreat her basically with the same immunotherapies that she had before, but it stopped working, right? And even though those therapies stopped working before, when we retreated her after the patient had tebentafusp, after some of those changes in the liver microenvironment were achieved, she achieved this really remarkable response. And so just to kind of summarize my piece, one, the clinical responses that we see with tebentafusp, it's a proof in concept. Immunotherapy can work in this disease, but we just have to use the right type of immunotherapy. To really optimize treatment, we have to address the barriers to effective immunotherapy, right? And those barriers may be, innate characteristics of the cancer. It might be innate characteristics of the organ in which it's growing, like the liver. And we do have to address the immune microenvironment, where the cancer is growing. Is that microenvironment susceptible to kind of the treatments that we have? 3, alteration of the immune microenvironment can be achieved. That is, the treatments that we have can affect the tumor, it can affect the immune system, it can affect the tumor microenvironment. And we have to take all of that into account when figuring out how to combine therapies, how to sequence therapies. And then finally, the development of new and effective combinatorial and sequential therapies remain of high priority. I just want to kind of leave the audience with this slide. When I meet patients, I like to give them buckets of therapy. How are we thinking about the strategies that we might pursue? And one is certainly, because this is a disease that likes to go to the liver, we have to strongly consider these what we call regional therapies, treatments directly into the liver. 2, we can certainly consider systemic therapies, oral medications, IV medications. But these are not mutually exclusive. We can certainly pursue concurrent strategies. Let's treat the liver and administer systemic therapy in a way that makes sense. And so with that, I think I'll end there. I'm looking forward to answering any questions. And I'd like to turn it over to Dr. Katz from TriSalus.
Thank you very much, Dr. Carbajal. And I also want to thank the Ocular Melanoma Foundation and Cure Insight for putting this together and allowing us to speak to this group. So when we think about all of the wonderful things that immunotherapy has done for so many diseases, including cutaneous melanoma, we also have to think about the patients that immunotherapy hasn't really helped as much. And uveal melanoma is one of those indications where we would all like to see immunotherapy perform much better. And I think to achieve that, we have to lend some thought to specifically what is driving immunotherapy failure in these patients. And there are 2 specific problems that we're focused on with the PERIO-01 study. And that's what I'm going to spend some time discussing with you. And so as a company, we're focused nearly exclusively on two organs, the liver and the pancreas. And uveal melanoma is the first indication that we are studying within the liver. And the reason why we're so focused on these two organs is that there are common problems, common denominators that are limiting immunotherapy success based on the immune systems within these organs and based on how drugs are taken up or delivered into these sites. And so these are the two problems that I mentioned. We're focused on immunosuppression, which is when cancer shuts the immune system off and renders patients less likely or unable to respond to drugs like checkpoint inhibitors. And we think this happens very specifically or in a very specific way within the liver, particularly in patients with uveal melanoma liver metastases. And the second problem is intratumoral pressure. Tumors within the liver and solid tumors in general tend to have very high pressures, so that when drugs are given systemically through an IV or through a port, or even directly into the liver, if we don't generate enough delivery pressure to overcome that barrier, it might be very challenging for drugs to achieve the concentrations that we would like to have the desired effect. So that's the second problem we're hoping to overcome. And the PERIO-01 study brings together what we hope will be two solutions for these two problems. And so we bring together these two solutions into what we consider to be a therapeutic platform because they work well together. We hope across multiple indications, starting with uveal melanoma liver metastases. The drug that we're studying in PERIO-01 is called SD101. It's a toll-like receptor 9 agonist, which means that this drug binds to a protein that's present on many of our immune cells, and it stimulates them or activates them to adopt an inflammatory posture and be more able to fight cancer cells. It leads to things like T cells coming into the tumor, T cells becoming more activated, and having more activated T cells inside of tumors is what we'd like to see for checkpoint inhibitors to work better, because checkpoint inhibitors are actually targeting the T cells and not the cancer cells directly. And there's a specific cell type that we think is very problematic in liver tumors called MDSCs, or myeloid-derived suppressor cells. And this cell type, we believe, is a big part of why patients with liver tumors in general and patients with uveal melanoma liver metastases aren't able to respond to checkpoint inhibitors. And we believe that SD101 is able to attack that cell type and eliminate it. And we're combining the drug with a delivery technology. This is a delivery technology or device that's FDA cleared. It's currently being used in the United States for standard of care therapies. But we brought it into the PERIO-01 study because we believe it could enable more effective and perhaps safer delivery of SD101 directly into liver tumors by overcoming this intratumoral pressure barrier. And our hope is that by doing so, we'll improve delivery of the drug, improve response rates, and thereby enabling patients to have better clinical outcomes. And by giving the drug directly into the liver and minimizing the exposure of uninvolved organs to the drug, hopefully we'll also be able to do this safely and minimize any toxicities that might otherwise occur. And so the uniqueness of the immune system in the liver has been very well studied. In some ways, we want our immune systems in the liver to be suppressed or quiescent because everything that we eat passes through the liver. And we have a lot of bacteria in our guts, in our colon, in our small intestines, and we don't want to develop hyperactive immune responses to these things every day. So the immune system in the liver, if you will, is designed to be somewhat suppressive. But when cancer cells are present in the liver, they hijack this and take advantage of it and limit the ability of patients to respond to the tumors or cancers on their own and limit their ability to benefit from immunotherapeutic treatments. And we've studied many different cell types in the liver, and the theme that emerges is fairly constant, that the immune system in the liver is suppressed, as I mentioned, and this is very problematic for cancer patients because tumor cells, as I said, can co-opt this and take advantage of it and make it very difficult for patients to do well with immunotherapy. And this one cell type that I mentioned that we think is very problematic in the liver that we hope and believe SD101 can effectively target, the myeloid-derived suppressor cell, has been very well studied over the years. Starting in the early 90s, the biology of this cell type began to become elucidated. The mechanisms by which this cell type shuts down T cells better understood. And more recently, we're beginning to develop an appreciation of how this cell type may function uniquely in the liver, and an understanding that we may need to target it differently based on the fact that we're focused on tumors within the liver and not other organs where this cell type may in fact behave differently. And one thing that we've learned from the checkpoint experience in other diseases, and Dr. Carvajal mentioned this, is that when patients have tumors in the liver, they tend to behave differently. And these patients actually tend to do worse with checkpoint inhibitors compared to patients who don't have tumors in the liver. So this study from Nature Medicine looked at patients with cutaneous melanoma, kidney cancer, and other diseases, and they compared patients with and without liver tumors. And again, the patients who had liver tumors, same diseases, just the location of the tumor differed. These patients did more poorly. They weren't able to respond to checkpoint inhibitors as reliably or as robustly as patients without liver tumors. So there's something about tumors being in the liver that's driving the immune system to be less active against the cancer and is limiting the ability of patients to respond to drugs like checkpoint inhibitors. And that's why the PERIO-01 study is so focused on driving the drug SD101 into the liver and hopefully leveraging the mechanism of action of the drug, which we think can stimulate the immune system in the liver effectively. And we hope eliminate that cell type, the MDSC, that is contributing to failure of immunotherapy in these patients. And SD101, like other TLR agonists or other drugs in this class, is able to stimulate multiple cell types, which we think is another attractive feature of the drug. Because when you think about immunosuppression in the liver and why checkpoint inhibitors aren't working well, it's a very complicated problem. And it might be challenging if we just go after one specific pathway or one molecule. So the ability of this drug and drugs like it to target multiple cell types, we think is an advantage when trying to enable immunotherapy in the liver. And this drug, as a class C TLR9 agonist, has properties that enable it to target myeloid-derived suppressor cells, which I mentioned we think can be very helpful for patients with tumors inside of their livers. And when we studied SD101 and compounds very similar to SD101, other class C TLR9 agonists, what we found is that when we treated a healthy patient MDSC in vitro or in a test tube with the drug, we can eliminate this cell type and cause these cells to die or become reprogrammed into more favorable immune cells. And in a murine or mouse model of liver tumors, we found that when we delivered the drug in the blood into the blood vessel feeding the liver using the pressure-enabled approach or the high-pressure approach, which we're going to be using or are using in patients, we found that we could effectively eliminate this cell type and allow the animals to respond more favorably to liver tumors. And that's what we're showing you on this slide, is that when we treated the animals with a combination of the regionally delivered TLR9 agonist, so giving it directly into the blood vessel, feeding the liver under high pressure, and combined it with the systemic checkpoint inhibitor, we get a much better tumor response within the liver. And that's the black line here showing you the lowest level of tumor growth compared to the other lines. Red is just checkpoint inhibitor, and purple is just the TLR9 agonist. So thinking about how we can apply this to our trial, in the trial, the black line is the combination that the patients are getting, the regional TLR9 agonist with systemic checkpoint inhibitor. And the red line is what patients are getting today in the clinic, which is just the systemic checkpoint inhibitor. So we hope by giving SD101 directly into the liver, we can change the immune environment, cause more T cells to be present, eliminate myeloid-derived suppressor cells, and thereby create a situation where checkpoint inhibitors have a much higher likelihood of working in patients with uveal melanoma liver metastases. So I'll summarize on this slide. So barriers to effective immunotherapy in the liver. While immunotherapy has achieved some wonderful things in other indications, The results, as we've discussed, have not been what we'd like them to be in the uveal melanoma population. And we believe by targeting these two specific problems, immunosuppression in the liver, focusing on myeloid suppressor cells, and the delivery barriers that I mentioned, we think that we can enable patients with uveal melanoma metastases to have a higher likelihood of response to systemic checkpoint inhibitors, and that we hope that this platform not only benefits this population, but other patient populations with tumors inside of their livers and the pancreas as well. So thank you for your attention, and I will stop here and turn it over to Dr. Weintraub.
Well, good afternoon, everyone. Thank you, Dr. Katz and Dr. Carvajal. It's always a little challenging to go third, and I'd like to start by a little bit reviewing some of the information that they've talked and how that leads into our treatment options for these patients. Here are my disclosures. So when we take into account what Dr. Carvajal and Dr. Katz talked about, really the goals of cancer immunoembolization, immunotherapy, is to make the host immune system really identify cancer cells as being foreign and target these cells for destruction. The challenge is that these cancer cells aren't foreign, and the response is really tightly controlled by the body. When you look at the liver, it's really a difficult area to treat, as we've discussed already. The challenge is really twofold. One is that the liver contains more than 70% of all tissue macrophages. It's really one of the most antigenic organs we have in the entire body. And it really has this innate immune cell population within it. And how do we address that population? Despite the abundance of cells, as Dr. Katz was saying, the liver tends to induce much more tolerance than immunity, really because of the unnecessary need to activate the immune system in an organ which is continuously exposed to food-derived antigens, probiotics from the GI tract, and we really want to prevent damage to the hepatocytes. And so this is really that conundrum that we look at when we go to treat patients who have liver disease from ocular melanoma. When we look at the SD-101 that we started talking about, we're really looking at trying to enable the immune response in the liver. It's a synthetic agonist that really stimulates the cells to release interferon and mature into APC cells, really to activate the T cell anti-immune response. And the question is, how do we get it there? So some of the initial studies, and we're looking here at some of the initial studies looking at SD-101 being studied in over 100 patients. And we see that when we give SD-101, it increases the total and cytotoxic cell tumor infiltrates. It induces interferon gamma gene cell expression and increases responsiveness to checkpoint inhibitors. So it really does all the things we need it to do to get the drugs to work better. When we look at the response rates, here it's being given intralesionally. So the first part was how to get the drug into the tumors. And so that was injected directly into tumors. So these were patients who had lesions that we could inject with the needle, percutaneously put a needle into the tumor, get very high doses of SD-101 into the tumors, and then intravenously giving a PD-L1 inhibitor, Prembo, into the patient systemically. And what we're able to see here in the ECHO study, this was just using a systemic PD-L1 inhibitor. We had about a 32% response from the tumors themselves. By adding SD-101, really ramping up the ability of the drugs to work, we went from a 32% response to close to a 79% response, just with the addition of that injection into the tumor. And here you can see the response rate in terms of tumor shrinkage in the vast majority of patients. So how does this take us to patients who have advanced disease? One of the questions that we always have is this safe? And when we looked at multiple studies across over 400 patients, the adverse effects of the SD-101, in addition to the PD-L1 inhibitors, is extraordinarily low. Like any type of drug, we get a lot of low grade 3-4 effects. And the events you can see here occur up into 30% of patients. We can talk a little bit more about that when we get into the study itself. However, the serious adverse events, the IR adverse events, treatment-related adverse events are running in about the 4 to 10% range, what we would expect, and treatment-related deaths in this study were essentially none. So how do we get the drug there? The initial thoughts were inject the drug directly into the liver itself. You get a very high dose of SD101 in the liver and affects the tumor. The challenge with that, as Dr. Katz was showing, on the initial side within a needle injection, you really get it localized to one part of the tumor. You don't get it to spread to the entire liver itself, to the tumors within the liver itself. By using the TriNav system and pressure induced delivery of the drug, the liver is unique. The liver has 2 blood supplies to it, and it's really one of the only 2 organs in the entire body that can regenerate. The liver and your skin are the only 2 organs in the body that can regenerate. As I was saying, it has 2 blood supplies. It has a portal vein, and that portal vein supplies about 75% of the blood to the liver, and a hepatic artery. That hepatic artery supplies the remaining 25% of blood to the liver. We take advantage of the fact that tumors within the liver like oxygen-rich, nutrient-rich blood. So because of that, the metastatic ocular melanoma within the liver, uveal melanoma in the liver, gets about 95% of its blood supply from that hepatic artery. What that allows us to do is to catheterize the hepatic artery, similar to how a cardiologist might come through your leg and go to the blood vessels that supply the heart. I'm able to come through a blood vessel and get out to the blood vessels that supply the liver. And once we're there, we're able to deliver very high doses of SD101 directly into the liver and really into the tumors in the liver while sparing the background liver. And so as you see here with the TriNav device, we're able to get very high volumes within the liver and very high concentrations of the drug in the liver itself. So pressure-enabled drug delivery allows us to come through an artery in the leg, trace all the way out to the artery in the liver. And this is really a standard technique that we use for many of the therapies that we give. This allows us to really provide very high doses of the drug. But then the key to this, to really overcome the differential that we're seeing in blood flow into the liver, is to do the pressure delivery, really to induce the drug to get out of the vessels and to get into that background substrate of the liver itself. The way it's performed is really sort of a traditional arteriogram. We come through a small puncture in the leg. Occasionally, we need to go through the arm. We trace out to the blood vessels in the liver. In the patients, this is all done under conscious sedation. You're very comfortable through the procedure. We often have you hold your breath as we're doing it. And the procedure is not that long. The entire procedure takes about an hour to an hour and a half. When we get out to the liver, what we're able to do is inject the blood vessels supplying the tumors. So here you can see with a standard catheter, when I inject the blood vessels, I see the blood supply to the liver itself. And here you can see the tumors faintly lighting up because they get that rich oxygen blood going into them. With the aid of the TriSalus device, I'm really able to pressurize this delivery into the liver. And here you can see on the arteriogram, increased flow in each of these tumors, really staining them well. And similar on the CT, here you can see a CT study done after the delivery with very little flow into the tumor here, or the tumor in this portion of the liver. But with the use of pressure-enabled delivery, we can really force that into the tissue around the tumors themselves. So we are now entering into the cohort B phase of the PERIO-01 study. The cohort A stage was really looking at the safety of this in terms of the tumor microenvironment. And that's really the key to a lot of the success that we're talking about for treatment of the liver. Really reprogramming the tumor microenvironment to allow the PD-L1s, the CTLA-4 medications, the Pembro, the IPI, to be effective. We're now moving into the cohort B stage of combining the SD101 with Pembro, and we'll hopefully soon be moving into the cohort C stage, where we be combining both the SD101 with a PDL4 inhibitor and a CTLA4 inhibitor as we go forward. With that, I'm going to ask Ashley Moody to take over to tell us a little bit more about the inclusion criteria for the study, where we are now, and where we're going to be heading shortly.
Thank you, Dr. Weintraub, and thank you everyone for joining today. I will be talking to you about eligibility criteria associated with this trial, and I'll also provide a high-level overview of the different procedures that are performed throughout the course of the trial. So for eligibility, we are enrolling adult patients with stage 4 uveal melanoma with liver dominant or liver only disease. So this isn't to say that patients can't have disease outside of the liver, but it's important that the greatest fraction of disease is located within the liver relative to other organs. Treatment with prior checkpoint inhibitors is allowed as long as there's a 21-day washout between the period of the last dose and initiation of screening for this trial. We are looking for patients with a good performance status, so we'll ask questions that allow us to understand how you're able to perform day-to-day activities and what your functional status is. And then we'll be looking to ensure that you have adequate organ function, which we can determine by drawing different types of blood work and by obtaining imaging such as MRI or CT scans in order to assess your organ function. And then this provides a high-level overview of the patient experience once enrolled in the clinical trial. So the SD101, as everyone has mentioned, is delivered in the interventional radiology suite, and it is a standard outpatient procedure. But for safety, the clinical trial does require one overnight admission following the initial infusion, just to make sure that patients tolerate both the drug and the infusion safely. And as long as this first infusion goes well, each of these subsequent infusions are performed on an outpatient basis. There are a total of 6 weekly SD101 treatment infusions that take place over the course of the trial. And this happens over the course of 2 cycles, and there's a 1-month break between cycles 1 and 2. We do have liver biopsies that are performed throughout the course of the trial, 1 before cycle 1 and 1 before cycle 2, which ends up occurring just before the 1st and the 4th infusions. Checkpoint inhibitors, depending on the cohort in which the patient's enrolled, are delivered per standard of care through a vein in your arm on a day separate from the SD101 infusion procedure. And we have treated patients in both the 2 and 4 milligram dose levels thus far. And we've seen encouraging safety data and no adverse events associated with either the drug or the infusion procedure itself. The checkpoint cohort, so cohort B that Dr. Weintraub alluded to, where we'll be administering the SD101 in addition to the nivolumab, is scheduled to begin sometime later this month or in May. And we're really looking forward to enrolling patients into that cohort. And then also TriSalus is providing logistical and financial support for patients who would require that if they need to travel greater than 40 miles to the study site in order to gain access to this clinical trial. So these are just, a high-level overview of the different eligibility criteria and the procedures that are associated with this clinical trial. And I would like to open it up now for Q&A for any more specific questions that anyone in the audience may have.
Ashley, if I could make a couple of comments regarding the patient experience while we're waiting for questions to come through. As Ashley was saying, this is done in the interventional radiology suite. These are done under conscious sedation. So you're awake and you're able to respond to us, but we usually use 2 medications, Versed and fentanyl, to keep you very comfortable throughout the entire procedure. In addition, to try to minimize the amount of time that you need to spend in the hospital, the liver biopsies are in fact performed at the same time as that initial treatment and during the 4th infusion. So it doesn't require a separate visit to the hospital. One of the things that we've noted when we do transarterial work, whether it's a yttrium 90, I know one of the questions was asking about yttrium 90 or transarterial chemoembolization, or immunoembolizations, is there's a very high first pass of the medications, meaning that when we inject it into the artery, the liver is taking up most of that medication. So fortunately, we see much fewer systemic side effects than you see from the conventional immunotherapies that are given through a vein, where it really affects your whole body. Here, the drugs are really concentrated into the liver themselves.
Awesome. Thank you everyone for being on. Thank you, Dr. Weintraub, Dr. Carvajal, and Dr. Katz and Ashley for clarifying kind of what's going on, what the research helps us like understand about the liver and the treatment of the liver. We do have quite a few questions that have come in, and just like Ashley said, we do want to open it up now for Q&A to these three experts so that you can hear from them. Just a quick disclaimer, just to remember, they cannot offer direct individualized medical advice over this presentation. We obviously, as patients, like we want to ask questions, and we have so many questions that sometimes can be very personal, but just keep in mind that the doctors can answer very generalized questions. They cannot offer direct medical advice. That in mind, we do have a couple questions that I'm going to go ahead and start going through, and then we'll pull some up from the Q&A. So how soon after being evaluated for the PERIO-01 clinical trial will I know if I'm qualified to participate? And how soon can I start? So who would like to take that question?
I can take that question. So screening procedures can be performed over the course of a couple of days. And once you're deemed to be eligible, you could technically receive the infusion within a few days later. We typically perform these infusions on a Monday or a Tuesday, but there's not a long wait between being enrolled and being deemed eligible and receiving the infusion itself. So less than a week.
Okay, that's awesome. Question number 2 is, does the stipend to participate in the PERIO-01 study include air travel and anything else?
It does, yes. For patients who need to travel to the site for treatment, it includes air travel, hotel. If you just need to drive, it can include gas mileage. It just depends on the patient's unique circumstance, and we'll work that out on a patient-per-patient basis.
Okay, so this kind of goes along with that question, or just is in very, related. But one of the questions that came in is, where is the PERIO-01 trial currently administered? Is it only at the Columbia location?
Very good question. No, it's at Columbia, but it's also live at MD Anderson in Texas as well, Jefferson, and the University of Pittsburgh Medical Center. And we have a couple of more sites coming online within the next few weeks, with an additional 4 coming on after that. So these sites are located across the nation. We've covered both coasts, middle of the country. So there are options. And as you can see at the bottom of this slide here, if you go to clinicaltrials.gov, we do list the different trials that are the sites that are hosting the trial. And also we have a website on our TriSalus homepage with more information.
Awesome. I love that. So we do have just a question confirming the number of treatments. So how many treatments total happen during the treatment process? And is it an ongoing treatment? Meaning, like, after you finish one phase, do you do it again? Or does it depend on the patient and how they respond?
Sure. Another very good question. There are a total of 6 SD101 infusion procedures that take place over the course of 2 cycles. So you receive the first 3 infusions during cycle 1 at a weekly basis, and then you take 1 month off. And then the second 3 infusions are performed during the second cycle, also at a weekly basis. That's for patients in cohort A who are just receiving SD101 therapy. For those patients, treatment stops after the 6th SD101 infusion. However, for patients enrolled in the cohorts that are also receiving checkpoint inhibitors, they'll continue to receive nivolumab up to 1 year following the final SD101 infusion procedure.
Okay. That is helpful. Let's see, where is this next question? What if I start the trial at one of the PERIO-01 sites and then I move closer to a different site that becomes available? Can I then switch sites for administration?
Yes, yeah, that would be an option. We would just need to review, of course, all of the safety and make sure there's a great PI handoff, but there's no reason that we couldn't work out those logistics.
Okay, that's good to know. Let's see. Number 4 question that came in, I guess, well, we might be on question number 6. I don't even know anymore. But can I contact one of the PERIO-01 sites myself to get the ball rolling, or do I have to go through one of my physicians and have a referral?
Oh, absolutely. It's encouraged. You can feel free to reach out to the site directly for more information.
Okay, that's good to know. All for advocating for ourselves as patients, right? Let's see, from Kristen Noko, regarding the PDL1 inhibitor, if a patient has a positive expression to PDL1, does that mean that immunotherapy may work better?
I'll defer to Dr. Carvajal or Dr. Katz.
Yeah,
Go ahead, Rich.
Yeah, in general, there's an association with higher expression of that PDL1 protein in response to therapy. I can say for melanoma, we don't use that for a treatment criteria, but we do like to see higher levels. but unfortunately for this, it's not an absolute marker. You know, even if you have high expression, it doesn't mean that treatment will work.
Yeah, that's exactly right. And the other thing that we tend to think about is when we look at PD-L1 expression levels as an indicator of response, typically we're looking at tumor cell or tumor expression of it, and other cell types like MDSC and other immune cells can express PD-L1. So when those cells express it, that may also enable patients to respond to drugs like nivolumab. And so that's something else to keep in mind. So just looking at it in the tumor may not tell the entire story.
Okay. And that was kind of like, I think it was you, Dr. Katz, who mentioned that in some cases you were seeing that after doing the PERIO trial, that they were showing better response rate to other immunotherapies. Is that kind of what I heard correctly?
Yeah, I think that's referring to a previous study that was done by a company called Dynavax, who owned SD101 before TriSalus acquired it. And they were looking at SD101 plus checkpoint inhibitor in cutaneous melanoma. And as Dr. Weintraub reviewed, that study showed that it was safe and well tolerated. So the combination did not result in any significant increase in toxicities over checkpoint alone. And that's when the response rate was 79% compared to the historical level in the 30s. And so that's what we're hoping to see in PERIO-01 by delivering SD101 in this way. And we don't have any data with checkpoint yet, but in the first few patients, we can say that the SD101 has been very well tolerated, being given directly into the liver. And when we look at the biopsies, we're starting to see those immune changes that we were hoping for that should and could enable checkpoint responsiveness, but we haven't treated any patients with that combination yet. And as Ashley mentioned, that's coming up soon.
We have a question from John, and he asks, what was the criteria to include the other drugs used in the trial in addition to the SD101?
So I guess that's a design question.
Go ahead.
Yeah, I mean, that's a great question. I mean, some of the challenges are when we think about these combinatorial strategies, right? What are the best partners? That's one thing you need to try to determine. And then, of those potential options, which can we clinically get? Which is available? So there are a lot of, there's a scientific question and then the practicalities of it. In this case, we have data that we think SD101 can enhance the activity of clinically available checkpoint inhibition, PD1, CTLA4, and PD1, CTLA4 is commonly used to treat uveal melanoma outside of trials. And so for those reasons, we felt that this was, a very promising approach and one that we could test very early on.
And looking at it from a slightly different perspective, and I agree with all of that, when we were deciding how to design this study, our fundamental goal was to boost the response rate to checkpoint inhibitors in uveal melanoma patients with liver metastases. And so we took a very careful look at what the problems were, what were the actual barriers or the critical barriers limiting success, as I mentioned at the beginning of my section. And when we looked at the tumors, it's really that these tumors are considered what we call cold tumors, that they don't have a lot of activated immune cells, not a lot of mutations. And so, is there a type of drug that can reverse this or improve this to stimulate the immune system, get activated immune cells to enter the tumor, thereby enabling checkpoint inhibitors to work better? So that's why we picked SD101. And then the delivery technology, we hope, will solve the needle injection limitation that Dr. Weintraub described. So it was really just defining the problem and picking things that we thought had a reasonable chance of solving or addressing those two problems.
Okay, so I think this kind of goes along with what you were just talking about, Dr. Katz, but it's kind of more of a confirmation question. So in other words, this treatment is it trying to teach the liver to do something that it should already be doing, or are we trying to teach the liver to do something it doesn't normally do?
Yes, maybe. I think it depends on how you look at it. I think the easiest perspective to take is that, as Dr. Weintraub and I mentioned earlier, the liver at baseline is suppressive or tolerant, so it doesn't respond robustly to stimuli like cancer cells. And then when cancer cells are present in the liver, they make that worse. They turn the immune system off even more. So I think the way I think about it is we're trying to treat a dysfunctional immune system in the liver. We're trying to correct what's wrong with the immune cells inside of these tumors so that they can then respond to checkpoint inhibitors.
Okay.
I would echo that. I mean, a lot of this is trying to change the tumor microenvironment that it's involved in the liver. And that's why a single drug solution isn't going to work. You know, we're changing the environment a lot with the SD101, then really allowing the drugs which we have seen to be partially effective become much more effective in that microenvironment. That's clearly the goal here.
And I
Okay.
think another point to make is getting back to something Dr. Carvajal said, is that we're really focused on the organ. You know, we've studied very deeply what we think is wrong with the immune system inside of these tumors in the liver specifically. And we think and hope that SD101 is well suited to correct the problem that exists in the liver specifically.
Okay, so this question from Linda says, do we know if the liver in non-cancer patients would normally be able to kill off uveal melanoma cells by itself? And the liver is in patients with uveal melanoma essentially just have a liver that isn't working as expected? Or would you say that the livers of all people universally would struggle to kill off uveal melanoma cells simply because of the function of the liver and the nature of the uveal melanoma?
I don't think that's an either or. I think it may be both. You know,
Mhm.
the liver
I was going to say, I
itself-
feel like it would be both.
Yeah, I mean, the liver itself is inherently immunosuppressive.
Yeah.
Like, the immune system in folks without cancer, you know, the immune system just doesn't function well there, and that's by design. But I think more and more we're learning that cancer itself can affect the way the immune system functions, the way certain organs like the liver function. And so I think it's both.
Okay. This is a little bit of a fast question, I hope, but is there a weight criteria for patients? I think this would be for you, Ashley.
Nothing specifically noted in the protocol, no.
Okay,
The only
wonderful.
the only thing from an angiographic standpoint is the weight limit on our tables is 450 pounds.
Okay. So will there be any sites open on the East Coast? I think this answer has already been given. East Coast, we've got the Thomas Jefferson University area, and then was there one in Florida or no?
Jefferson.
Jefferson.
Yep, and also University of Pittsburgh.
Okay.
And of course, Columbia. And then we'll be opening actually MGH soon as well.
All right. And then we have another question. Is prior treatment with Y90 allowed?
It is allowed. The one thing that we check is to make sure that blood flow to the areas where the tumors are located is preserved. And that's usually the case in patients who get Y90. So as long as we can confirm that blood flow has not been interrupted from the Y90 beads, then the patients can participate.
Okay, and where on the West Coast, sorry to bounce back, but this attendee says that her question was actually not for the East Coast, it was for the West Coast. Where on the West Coast can you remind them where they can find the treatment sites?
UCLA, they're not open yet, but they will be. Stanford will be open quite soon. California, Seattle, Washington, UWash. Those are the three that we're looking at right now.
Okay, wonderful. Let's see. I think there's one here at the top. What kinds of tests should be done for a change in tumor microenvironment? Would another biopsy be needed?
So within the trial, there are three biopsy sessions. As Dr. Weintraub mentioned, there's one right before the first infusion, then one right before the fourth infusion, then there's one a few weeks after cycle 2. There's nothing else done in terms of getting more information or trying to get a closer look at the tumor microenvironment. So it's just those 3 time points that we sample the tumors within the trial. It's not something that's done in routine clinical care, but within the trial, that's when we do those procedures.
Okay, so procedurally, how many days after the liver-directed therapy is the infusion of the PD-L1 and the CTLA-4?
They take place concurrently, plus or minus 1 day of the SD101 infusion procedure. During
Okay.
cohort B, where it's just nivolumab, it's every 4 weeks.
All right. Liver biopsy, is that required for continued enrollment?
No, it isn't.
It's not. Okay. So this is, I guess, maybe more of my own question. I'm assuming to have the treatment, you have to have the biopsy. You said it's done concurrently at the time of the beginning of the treatments. That biopsy is to confirm the presence of uveal melanoma as the actual tumor cells, correct?
Well, typically that's known coming into the trial. So the purpose of the biopsy, it's to get information about drug delivery, to get information about how the drug's affecting immune cells inside of the tumor, and also to get some information about response, because imaging can be a little bit challenging at times, particularly in the short term. And so the baseline biopsy is to understand what things look like before treatment. And then the second and third sessions are to understand what happens after cycle 1 and then cycle 2.
Okay. Yes, that makes sense.
And just something to highlight is we, for any of these clinical trials, we know it's a lot to ask from patients. We do these trials because we believe that these treatments may help, right, fight the cancer. But we also need to figure out, what's the likelihood of these treatments working, right? Like, are the treatments doing what we expect it to do? And so that's why we ask, people enrolling in the trial to do these biopsies. Are we changing that microenvironment? What are we doing to the tumor? The only way to answer that is with the biopsies.
Yeah, that makes sense. So I'm assuming that if someone has been previously treated with any other treatments and they have had a biopsy done for those treatments, they would need a new biopsy going into this trial. Okay. From John, if 2 cycles of treatment are completed, what will determine what happens next? Is that just, again, back to the biopsy and how you're responding?
It just depends on, sorry, go ahead. It depends on the cohort in which the patient enrolls. So if they're in the monotherapy cohort A, that's the end of treatment just by trial design. But if they're in cohorts B or C where checkpoints are administered, then checkpoints continue after the second cycle.
So we have a question about enrolling in cohorts. Do they get to pick which cohort, or are they randomly assigned a cohort?
It's sequential.
It's
So
sequential.
they don't get to pick.
Okay, so it's basically if you're person A, person B, person C, person A would go to cohort A, person B would go to cohort B, and person C would go to cohort C. And then you would start the pattern over?
It just depends. They open sequentially. And
Okay.
so, for example, cohort A is open now. When cohort B opens officially, that'll be the only cohort open. And so patients, whoever enrolls during that period of time will go into cohort B.
Okay, gotcha.
Then when we complete B, we open C and so on.
Okay, that makes sense.
So from a safety perspective, right? Because we want to make sure the SD101 by itself is safe, and then we'll add the nivolumab to that, make sure that's safe, and then do the combination of immunotherapy with SD101.
Back to our weight question. The question was and is for those who are unable to gain weight and are deemed underweight. So I guess their concern is like basically for the toxicity and for the concern of like maintaining their overall health if they have already had weight deterioration due to cancer treatment and the cancer, already working its damage.
So it's really more about overall performance status or just general health status. So irrespective of the weight, if a patient is in good shape and meets all the enrollment criteria and the performance status is above a certain threshold, and the physician feels it'll be safe for the patient to enroll, then the patient can enroll even if there's been weight loss or the weight is low.
Okay, so those eligibility criteria are evaluated on an individual basis.
Yeah.
Okay, let's see. Since it's delivered, this delivery system is delivered with high pressure, does it really hurt? Is a question that just came in.
Patients are very comfortable. The patient doesn't even notice. You don't really sense pain within your liver. We're well within the parenchyma of the liver. So when we elevate the pressure of the infusion, there's no systemic feeling for the patient themselves.
Okay, this question is about, oh, go ahead.
Sorry, I was going to mention quickly that the device that we're using in the study, as I mentioned, it's FDA cleared. It's actually been used in over 15,000 cases with an excellent safety profile. So even though it is augmenting the pressure of delivery, it's not done in a dangerous way. There haven't been any significant incidences of vascular or vessel injury or trauma So we know that the device can be used very safely in patients in the livers.
Okay. Is ongoing, I guess this is for you, Ashley, is ongoing imaging, so the MRIs that follow to evaluate the effectiveness of treatment, is the ongoing imaging covered by the trial as well, or is it only the initial treatments as well as the travel?
Yes, so a couple of the imaging procedures take place at the frequency that you would normally have them in clinical practice. So those would be submitted to insurance, but anything that takes place more frequently than would standardly be performed, the trial will cover.
Okay, so basically, it will be covered if it's in excess from what standard procedure requires.
Yes.
Okay, I am looking to see if I missed any major questions. As far as the newer locations coming up, upcoming locations, is Denver one of those lists? Yes, okay, Denver is one of those lists, one of those in the list. Do you have to lay flat for 6 hours after treatment?
The vast majority of cases, assuming the anatomy is fine, we use a vascular closure device. And so you're up and ambulating in 1 hour to 90 minutes.
Okay. What's the estimated size for the planned cohorts? I guess number of patients.
Sure. So we've enrolled 7 patients to date in cohorts B and C, anywhere from 6 to 12 patients, depending on how patients tolerate the treatment. And then in the phase 1B portion, up to 40 patients.
Okay. All right. I am not seeing any other questions. Do you guys have anything else that you guys wanted to share to wrap up?
Yeah, I just want to thank Cureinsight again and the Ocular Melanoma Foundation for allowing this to happen. I hope it's been informative for the patients. And, as Dr. Carvajal mentioned, we recognize what an effort and undertaking it is for patients to participate in these studies. So I want to thank all of you that have taken part in clinical trials or are considering it going forward.
Oh, I think this was wonderful. And thank you, all of you, to being here and for participating, for being part of the planning process for the last month. Like, it's been amazing.